Thank you, Raj. That was fantastic.
Our next speaker, it's a pleasure to introduce. This is Dr. Lisa Cox. She works as a pediatric neuropsychologist at the Nemours Children's Hospital, participates with the epilepsy patients at the Epilepsy Center at Nemours. And she's going to be speaking with us today about key components to successful transitions in epilepsy care. And so without further delay, I'd like to call Dr. Lisa Cox to the podium, please.
Good afternoon, everyone. I'll put this down. Let's see if I can figure out how to work this. So what I'm going to talk about is we had Dr. Abram give us a nice overview of epilepsy, and Dr. Sheff talked with us about some of the transitions actually in the condition of epilepsy. And I'm actually going to talk about the nuts and bolts of transition. What is it, and how do we do it? That's not right. So I think it's important for us to, one, start with a definition so we all are aware of what we're talking about. And transition is defined as a purposeful, planned process that addresses the medical, psychosocial, educational, vocational needs of adolescents and young adults with chronic physical and medical conditions as they move from child-centered to adult-oriented care systems. Now, there are a couple of things that are really important to consider in this definition. The first few lines says a purposeful, planned process. So transition it's not an event. It's not, sometimes I'll see an adolescent and they're 17 years old and all of a sudden they'll come in and for some reason it will just occur to me, oh, you're 17. You know, at Nemours, we only see up to 18, so we're going to have to start to figure out what to do. That's an event, not a process, not the way you want to handle it. So it's not solely also determined by chronological age. A lot of individuals with epilepsy have developmental or intellectual delay, so we also want to make sure that we are aware of their developmental age in addition to their chronological age, and that's actually what will drive the decisions that we make. And we also want to have some flexibility. We're going to talk about the stages in a few minutes, and we need to be able, sometimes we have to go back to an earlier stage, or maybe we'll skip certain parts, so we have to be flexible in our approach as well. Usually it's a multidisciplinary team. We may have a social worker, a psychologist, a neurologist, a number of people that will assist you going through the transition process. And the process is one that's collaborative. It should be one that involves the adolescent, the patient, or the adolescent, the parent, and the healthcare provider. Now that sounds like that's a pretty obvious thing. However, there have been numerous studies, including one that was conducted in 2002, in which 40% of young people reported that they had minimal to no involvement in the planning process. So this lets us know that we have a long way to go to make this a collaborative and successful process for all involved. Now, preparation should span years with a gradual expectation that the child and or adolescent take on increasing responsibility and expanding knowledge base. So the key to a successful transition is we want to strengthen independency and encourage management right from childhood. We do that by starting pretty early. So we can start developing independence in very young children. In fact, 3 to 5-year-olds can start to develop independence and competence. We can have them help with daily chores, have them have daily responsibility, maybe help clean up their room, help you sort laundry, help with pet care, just something that they can do to help them to become more independent. And as they get a little bit older, when they're 6 to 11 years, we want them to be involved in responsibility for self-care, now really responsible for cleaning their room and things of that nature. And by doing this, we allow the child to develop confidence and a sense of capability. So they feel that I am capable and competent and able to accomplish things, which is very important because what we want to do is we want to lay the foundation. As I said earlier, transition is a process. In order for us to go through the process, we need to have a solid foundation. And we certainly can't start developing that foundation at 14. Now, before we go through what's involved in the process, I think it's important to talk about perception, because perception can be reality, because that's what we think. Well, actually, sometimes perception is not reality. We know that because we used to think the world was flat, for example, and it actually is not. We know that both parents and adolescents have differences in how they view pediatric versus adult care. Both parents and adolescents tend to see adult care as not really fun, boring. So some of the things they'll say when they're asked, well, what do you think about the transition and going on into an adult facility? They'll say things like, well, there are no books, no toys, no TV, no listening to music, no joking around, not anything. So that sounds pretty dreadful, doesn't it? But that's what they think, because that is a huge contrast with a children's facility. The parent, on the other hand, says things like, I don't think there will be as much care, personal and physically, towards them, and the parents will have less say. Care will be different. So this perception will have an impact on how smooth the transition goes, because it sounds like they're sort of dreading the transition. And that, in fact, is not the case. And what we need to do is, as providers, we need to make sure and educate both the parents and adolescents about what actually happens in an adult facility. And when at all possible, we should allow the adolescent to have an opportunity to visit the facility, visit the practitioners before they transition, so they can see that these are not, really scary, mean, serious people all of the time. And also involved in perception, there actually happens to be a difference between what the adolescent thinks of transition versus what the parent thinks of transition. Now, typical of the developmental age of an adolescent is they are usually like, it's no big deal, I really don't care. Apathy, lack of concern tends to be the overwhelming theme when the adolescent is asked, what do you think about moving on to another facility? Some of the comments they make are things like, they're a hospital too, so they probably know what they're doing. So I'm really not worried. Others take a wait and see approach, and one comment that highlights that is, I need to get used to it. I've known my doctor awfully long, for 18 years. But I'll just see what's going on. I'll just see what's going to happen. Actually, I'm getting too old now for the children's hospital. Seems to be the right age for transfer, because I'm an adult now, aren't I? And this is from a 19-year-old male diagnosed with cystic fibrosis. Now we're going to contrast this with what the parents perceive and how they feel about transition. Parents, on the other hand, tend to be more worried and anxious. They make comments such as, I'm sick and anxious about the different levels of care and understanding of my child. I don't want to leave the trusted environment where everything is familiar and where you are in charge. Still, raising kids implies that you have to let them go and accept that they make their own choices. I don't like it that he had to go, but I saw the necessity, and now I see that it's good. Also, another important issue in transitions would be the shifting roles. So the responsibility shifts from the parent to the adolescent. And before we go on with this, I can just tell you that it's very difficult for a parent to step backward and encourage independence. It can be a challenge for them. And I could tell you myself what that experience was like for me, actually quite recently, and I'm well over 18, as I'm sure you can guess. My mother came to visit me about a month or so ago, and there was a situation, I guess I shall say, and she decided that she was going to handle the situation without consulting me. So afterward, I said, "Mom, I can't believe you did that. That was so inappropriate. You were way out of line." So then she says to me, "Well, I carried you for 9 months, and I love you very much, and I will always protect you." My response was, "Really, Mom? You're going back to my prenatal development? Come on." So that sort of shows the dynamic between the parent and the child, and how that never, in some essences, remains the same, no matter how old you are. And we can imagine if you are suffering with a chronic medical condition, how much more pronounced that relationship will be, and how much more difficult it will be for the parent to step back and say, "Okay, I'm going to let you handle this." And we've actually looked at what adolescents actually have to say about transition and how their parents respond. And in one study conducted in 2004, in that study, 44% of the adolescents with sickle cell disease stated that transition programs should offer ways to help parents let their adolescents grow up. So there's a strong need to hold on. So what does that mean? There are certain challenges for both the parent and for the adolescent. For the parent, they're challenged with gaining trust in their child. The parents have questions such as, can my child, the adolescent, the young adult, really take up the full responsibility for treatment? I have been the one that's been involved in this for the past 17 years, and I'm really not confident that they can do it. So that's what the parent has to try to figure out how to work through. And on the other side, the child or the adolescent young adult, they need to gain the trust in their own capabilities, and they need to develop trusted relationships with the new healthcare providers. So they need to be able to pick things up and move from this point forward. Now, we nevertheless have expectations about transitions, and an unrealistic expectation would be to assume that young adults and parents will effortlessly move from managing together to solo management in the adult world. So we're moving from a family-centered approach to an individual parent-centered approach, and that is not an easy transition. And because of that, we need to make progressive handover responsibility. So we need to do this incrementally as opposed to all at once, which would promote more success. So when does the process actually begin? Well, we actually know that the process of transition typically begins around 12, which may seem actually awfully young, but it is a process and it does take some time. But remember, we talked about earlier that we really want to start fostering independence way before that. So we want to start that at maybe between 3 and 5 if we can, and then start focusing a little bit more on the actual process of transitioning around the age of 12. And that's what actually, this statement is just from the Children's Medical Services, and when they actually start the process of transitioning children who receive services through them. So we have, this is actually from the Children's Medical Services. There's a booklet, and I think some of you may have that, called Envisioning My Future. And these are the 3 stages that they propose to go through transition. The first stage they refer to as assuming new responsibilities, and this is primarily for children that are 12 to 14 years old. Now again, remember, we do have some children who do have developmental delays, so for those children, so we could possibly have a 17-year-old who may be 3 or 4 years behind their peers, so they would, of course, also fall in this stage as well once they reach that point. So here is when we start talking to the adolescent and the family and introduce the idea of transition to adult care. And we want the young person to gradually become an expert in their health condition. So we talked earlier about what epilepsy is. So we want the young adult and adolescent to know what a seizure is, what type of seizures do I have, what medications am I on, what are the implications if I miss a dose, what should I tell people in case I have one. Those are things that really help empower them and really help them to get a good, solid understanding of their medical condition. We also want them to start actively participating in their health care. One goal could be you can have the adolescent ask at least one question during each appointment of the provider to help them get a better understanding. Another thing I do is I have everyone that comes to see me signs a consent form, and there's also a line for assent, which means that the assent is for the child, someone under 18, agreeing to participate in the evaluation, whereas consent is providing permission to conduct the evaluation. And I usually have the parent sign first, and then I'll give it to the child, usually the 12 or 13-year-olds. And they usually will ask me a couple of questions. One, they'll want to know if they should print or write in cursive. Then the second question is, do you need my last name? So once we get that sorted away, they usually sign it, and then I say to them something like, well, thanks for giving me all your video games or your firstborn child. And they look at me really puzzled, and I say that to them because they never read it. So I'm trying to let them know that if you're going to sign something, it's very important that you read that document, because if you don't, you could do something that you may not want to do. So that's one way it can be done actually in the provider's office as well. The next stage is called practicing independence, and this would be for adolescents between 15 and 17 years of age. And here, by this point, we've already been talking to them now for 2 or 3 years about the fact that you're going to be transitioning out of the pediatric health care facility or the children's hospital and going on to an adult hospital. So you should start feeling a little bit more secure and understanding of that. We also want to provide them with time and guidance to practice skills, such as we want them to start making appointments with supervision. You want them to be able to summarize their health history to their healthcare providers. We want them to start asking the doctors more questions and answering more questions. And we also want them to have an opportunity to spend some time alone with the physician. So the parent and the child and the physician can be together, and then at some point let the child spend some time alone where they can talk and just ask questions and just sort of get used to the idea of, I'm going to be seeing the provider without my parent present. Also, they should be involved in decision making. So when a decision is made, it can be made including the adolescent, the child, the physician, and the parent. One thing that we don't want to do is we don't want to be dishonest or not truthful. So for example, sometimes when a child is told about transition, especially if we've not really given them enough time to prepare, they become anxious and worried and feel like, I have been in this environment for so many years and I know everyone and everyone here loves me and I absolutely don't want to leave. Sometimes they may become tearful, may start screaming, and things of that nature. And then as a provider, your response is, okay, I want to calm you. I'm going to do whatever it takes. So you know what? Sometimes we make exceptions. And I'm going to talk to some of the individuals in our administration and see if we can keep you here a little bit longer. Well, that's not being truthful and honest. One, we can't keep them here forever, so we're just delaying the inevitable. So let's say we are able to keep the child until 19. Well, we're still in the same position when they turn 20. And they really need to, in order to be empowered, you really need to know the truth. So we don't want to placate them. We want them to be able to understand at a level that's developmentally appropriate that this is a natural phase in life, and we want to help you to accept it and move from here. The last stage is called taking charge, and this would be for ages 18 and up. At this point now, The adolescent or young adult should be quite knowledgeable about their medical condition. They should have a good understanding of epilepsy, their type of epilepsy, know their seizures, know triggers and things of that nature. They also should be more independent in carrying out and directing others to carry out their healthcare task. At this point, the appointments can still include the parent, but it should be the adolescent that's answering all of the questions and also asking questions as well. And they should have a more considerable amount of time where they see the physician independent without the parent present. So now that we are at age 18, now the issue comes up of guardianship, because at this point, once a child turns 18, they are the ones that legally consent to treatment. The parent no longer has control. So what do you do if you feel like, well, I'm not really sure if my child can handle this and I don't think that they're able to make these decisions? This is where guardianship comes in. And guardianship is a process in which you or an individual would petition the court to determine the competency of the individual and ask to be appointed the guardian if that person is determined to be incompetent. The petitioner will need to have legal representation, and an attorney will also be appointed to represent the individual or the adolescent. After that occurs, and a committee will be formed. It usually consists of a physician, a psychiatrist, a psychologist, and they will examine all of the information, and then they will then make recommendations to the court. After this is done, the judge will then look at all of the information and at that point decide whether or not the individual is competent or incompetent. We can have full guardianship awarded, in which the individual who's the guardian has total and complete control over all aspects of the individual's life, and we can also have partial guardianship, or limited guardianship, in which there is some area. So for example, guardianships may only apply to healthcare decisions, or it may only apply to financial decisions, and the other things the individual will be free to make their own decisions. The guardian is then going to be responsible for making those decisions, whether they're healthcare, whether they're financial, whether they're housing. That will be their responsibility. However, they are not responsible for providing for the individual. So it's not a financial arrangement, it's just one in which you are serving to help someone who is incompetent or unable to make decisions for themselves. Now there's another type of guardianship, and this is referred to as a guardian advocate. And this is for individuals with developmental disability. And the process is a little bit different here. Now, the person petitioning the court must provide the court with medical records, school records, and other records to show the person's ability. So they have to show that the person has some type of developmental disability prior to petitioning the court. At that point, the judge will look at that information and once again determine competency. And everything at that point is the same. It will be the same process where it can be full or limited guardianship, or of course, the individuals could be found to be competent, and that means they'd have total control over everything. There is, with guardianship, every year there is a process where you have to go through to provide information about what you're going to do for the upcoming year for a guardian advocate that sometimes is waived. So once that decision is made, then usually that pretty much remains for quite some time. Now, sometimes you may not want to, or actually an individual may be found competent, because competency again is a legal, not a medical term. So it's based strictly on interpretation of the law, which is different than what we may see in a medical arena. So another option would be, in managing financial matters, is to become a representative payee. And this would involve being assigned to receive government benefit checks if the government believes that the person with a disability cannot manage their money. So you can be the payee and receive the SSI checks or SSDI checks for the individual. If that is not something that you want to do, then we can take it down to a level that's even less limiting, and that one would be simply having a joint bank account that would require 2 signatures. So if you're concerned about the individual's ability to manage their money, and you're not able to get guardianship or not interested in for whatever reason, and you're not able to be a representative payee, then you can also simply go to the bank and open up a joint account, and if both signatures are required, hopefully that should help somewhat with the managing of funds. Now, also moving on to what happens at around this age is that the child will finish school, and now we have a difference in how they're eligible for services. So there are 2 different ways that we become eligible for services. We have entitlement programs and we have eligibility programs. Entitlement programs are programs that are under the law, the IDA and the Rehabilitation Act Amendment of 1992, especially Section 504, and this is where the 504 accommodation plan is incorporated for those of you who have heard that before. And what this states is that elementary and secondary schools are required to identify students with disabilities and provide accommodations when the disability affects their education. The burden to identify the disability generally falls on the parent of the child with a disability, and this ends when the student leaves public school. So this is an entitlement simply means just by virtue of having the disability or the medical condition, you receive services. That's all you need to do. I have the diagnosis, that equals I will receive service. Then after graduation, we move from entitlement-based services to eligibility-based services. So everything in the all-adult services are eligibility-based. What this means is that the individual needs to meet certain requirements that include financial eligibility criteria to receive services. So it's no longer sufficient to have a diagnosis or a disability. You now must meet the criteria. And even if you do happen to have the diagnosis, if your financial status is one that is above what it should be, then you will not receive the services. In post-secondary education, unlike elementary and secondary school, there are no entitlements. So if a child had an IEP, individual education plan, throughout their educational career, should they decide to go on to college, the IEP will not follow them there. What they would need to do at that point is they would have to, it becomes their responsibility now to notify the school that they have a disability and to request that accommodations. And accommodations at this level often do not mirror those at the elementary and secondary school level, so they tend to be less intense than they previously were. So even if you are found to be eligible to receive accommodations, it will not be an exact replica of the IEP. So this, again, it places a burden on the individual. They have to disclose to the school's Office of Services for Students with Disabilities that they have a disability. If the student and or the family decide that they do not want to disclose that information, then the school is under no obligations to provide accommodations to the student. And moving on with transition, so now we've graduated from school, and now we have to think about work. What are we going to do? Some individuals decide to go on to post-secondary education. Others work, and that would be under the Department of Vocational Rehabilitation. Transition planning here is mandated by the Individuals with Disability Education Improvement Act of 2004, and states that vocational rehabilitation counselors must participate in transition planning before the student exits school. So we need to have a plan in place for what the child or the adolescent will be doing once they graduate. The vocational rehabilitation counselor is usually assigned during the last 2 years of school, but the parents and the students can request that their participation be a little bit earlier, as early as 14, via one-step careers or through the school. And in general, it's often recommended that the earlier you request voc rehab services, the better, because it usually is a lengthy process, and if it's requested too late, then the individual may have time to finish school before we get at all of the things that we want to get in place for them. So it's usually a good idea to start as early as possible, somewhere between 14 and 16. And under the vocational rehabilitation, services are guided by an individualized plan for employment. It's similar to an IEP, but it's more focused on work and employment. Services may include self-advocacy training, teaching the individual how to speak up for themselves, development of employment readiness skills, adaptive driving evaluation and instruction, and job coaching. Now, there are several options for employment. The first would be competitive employment. In this type of a situation, the individual will be expected to perform the essential functions of the job as the same level as an individual without a disability. Now, the individual may request some accommodations under the American with Disabilities Acts. However, the accommodations cannot fundamentally alter the nature of the job. So the accommodations would be things like adaptive seating, large print, computer input devices, but essentially the individual would be expected to perform the task at the same level as someone, again, without a disability. We also have work-study employment. This would be for part-time work for students. It can be either on or off campus if they're in college. We also have supported employment. Supported employment is an inclusive setting with ongoing support services for individuals with disabilities. Sometimes it's referred to as sheltered workshops. And this is generally done through the Vocational Rehabilitation Department, so it's usually a state-level program, and everything is pretty much set in place if that's the route that it's decided that we would pursue. We also have another option called customized employment, and this is actually a blend of service. So it's designed to increase employment for individuals with significant disabilities through such things as self-employment, entrepreneurship, job carving, personal agents, and customized training. And also, finally, we have, which is not necessarily optimal because it's volunteering, which means you will not garner a wage, but that also is an option for some individuals if they would like to pursue that. And one thing that's also a key throughout is psychosocial support. We know, as we've heard earlier, that there are higher rates of depression and anxiety among individuals with epilepsy, as well as several other chronic medical conditions. So at every step of the way, even for a young child, you always want to ask questions about how they're feeling, notice how they're adjusting to chronic illness. Also, just sort of really paying attention to how they're